Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone. Welcome to the Codecast podcast. My name is Terry Fletcher. Happy to have everybody today at our 117th episode of the Codecast. Again, welcome to 2020. Hope you're having a good new year of opportunities. And today's episode, I wanted to touch on the new E&M changes that, yes, they're going to take effect in 2021, but I've had a lot of emails, a lot of people panicking about how to prepare your practice for the E&M changes. So I'm going to give you a list. You know me and my top 10 lists, and I realize it's not the top 10 Tuesday, but I think this is helpful just to give you some tips on how to prepare. And some of this comes definitely from the American Medical Association suggestions, but I've kind of embellished a little bit just because I think there's some nuances that maybe they didn't touch on within some of the topics. So we're going to talk about that today. And also making sure in that planning that you understand that it's not just about code changes. It's about operational, infrastructure, administrative workflow. And there's all things that are going to result from this overhaul that, again, will be effective in just 11 short months. So hopefully we'll keep you prepared and it'll keep you out in the forefront of these changes so that you're not waiting till the last minute. You need to have a plan in place. And this is what I'm hoping this does for you because there's a lot of work to be done. And so I'm going to have some webinars in how to actually implement what the changes actually are. I know a lot of you do internal auditing. You know, I'm an external auditor. So basically, I'm almost 80% auditing right now. Yes, education and coding and reimbursement and all that and billing, but I audit probably most of the time because I'm just looking at so many different things for practices, and practices are contacting me daily saying we need help. And so this is something we take a look at. But first, the Codecast podcast is also brought to you by the Mayo Clinic, an integrated clinical practice, education, and research institution specializing in treating patients, the #1 hospital in the nation. Know where to go: Minnesota, Florida, Arizona, mayoclinic.org. We're very excited to have them as a sponsor today. Okay, so what do you want to do? You want to identify a project lead. This is a project. Don't let anybody tell you it isn't. This is definitely a project. And when you have to transition into brand new information, new revised coding guidelines, it's going to require staff education. It's going to require review of internal policies, review of procedures, and financial tracking, because I'm seeing all kinds of different suggestions on how to create a workflow process that's going to help your physician. So specify a project lead who's in charge with leading the transition. You can also get pointers for how to lead the change in your practice from the American Medical Association. They have something called Steps Forward module, and it's an organizational leadership and change management. Just look to see what you can do. I like it. I looked at it, I reviewed it. I thought it's okay. I think there's a couple things that I don't necessarily agree with, but I think it can definitely help you, at least to get started, to give you some direction. And so just get somebody in your office that can be that project lead, because again, this is going to be one heck of a project. Number 2 would be schedule team preparation time. So the best way to educate your practice about these upcoming changes would be to walk them through, so you have to walk through them with the practice physicians, other clinical staff, administrative personnel. Practices are going to need to schedule time for in-person meetings, and it's really to review the changes, really to the surface, and then address any questions. I know there's some outlines, again, on the AMA website that is called Steps Forward, again, that kind of shows you how to run an efficient and productive team meeting. I've also started a podcast on another site for this as well. And AMA actually has a podcast to address the topic, and it's called AMA Moving Medicine. So podcast is a big deal right now. Everybody really has time more to listen in their car or listen to in the morning when they're getting ready on how to do things more than kind of read up on it. But I'm always reading up on everything and I have to make the time for it because these changes are going to be big. And the thing is that it's not complete overhaul. It's only on certain codes in the E&M section. So you have to get updated. Otherwise, you're going to be providing services that have the wrong documentation effort, and you don't want to do that to your physician. Update practice protocols. So practice procedures and protocols must be updated to be consistent with the new guidelines. So AMA recommends leveraging your practice's established coding resources and expertise early in the update process. So they want to make sure that you've got people in place within your team that maybe are the point people for the E&M services, and then making sure they understand the current guidelines and how to roll them into the next set of guidelines. Number 4 is consider coding support. So not only can you use our team, you feel free to contact me and we can schedule a training session for you, do it personally for your office, or you can also go to different educational websites and see what modules they have there. It can help just reduce that administrative burden and what this is going to take to really take on this project. But really consider getting some external support too. And again, contact me. We're here to help. This is what we do. We educate, we audit, we review, and then we help implement. Number 5 is be aware of medical malpractice liability. And this is the biggest one. This is one that I really kind of slid in there as well. Even though the requirements around E&M documentation have, I wouldn't say technically have lessened or become, let's say, more flexible, physicians should still carefully document the work that's being done and how to protect themselves from medical malpractice suits. So there's some issues I've noticed on the AMA Litigation Center that talks about, advocates for the physicians on issues related to liability and resources on this topic. Because think about it, if the physician is now being told that they don't have to do what I like to call a comprehensive or complete history and physical portion of their E&M as part of the scoring to get to a certain level of service, that everything's going to be based either on time or medical decision making, then at that point, it's subjective. But what if a patient has, let's say, an underlying problem that has nothing to do with why they're being seen for that encounter, and it's something that comes up later? Is that doctor now going to be liable for not taking a complete history? And those are things that you need to know, because just because you're allowed to, kind of relax your guidelines doesn't necessarily mean that you want to. So we have to really guard against that. Which takes us to number 6, guard against fraud and abuse law infractions. So the False Claim Act and other federal and state fraud and abuse laws still remain in effect. So although the new E&M office guidelines will allow greater flexibility, you still have to document appropriately and guard against, inadvertently overbilling. So if your practice does bill appropriately under the new E&M rules, but still receives an overpayment demand, the AMA resources, they are kind of showing you how to navigate the audit and appeals process. And we can help you with that as well. I think it's going to be interesting how they're going to come out and say that you got an overpayment if the rules are going to be so ambiguous as far as what your compliance has to be. Number 7 is update your compliance plan. So many practices have a compliance plan to help avoid ethical and legal mistakes. And if you don't have one, you realize that if you are a Medicare provider, it's required. Medicare hasn't, full-fledged sent out compliance police, but the U.S. Department of Health and Human Services says you have to have a compliance plan in your practice if you bill to Medicare. So if it's ever checked and you don't have one, be aware that they can just take back all the money. So as your practice undergoes the transition to the new E&M guidance, ensure that your updated protocols and procedures remain consistent with your current compliance plan. So what happens if your physician doesn't document or code a certain way, and what are the ramifications? That's the biggest thing with the compliance plan. It means that there are consequences if you don't follow it. It can't just be a suggestion or guidelines. It has to be, this is how we do things here, and this is what has to be done. And if you don't, here are the consequences. Check with your local electronic health record vendor. So your EHR, your EMR vendor, practices need to communicate with them, because they're going to have a schedule for implementing these services as well. And AMA is working closely with many EHR vendors, eClinicalWorks, NextGen, Doctors Management, Athena, all of these different vendors across the country, hopefully making it as straightforward as possible to implement some of these changes in their system. Then you need to assess the financial impact. So guard against unanticipated financial impact by understanding the rules in advance and performing a prospective financial analysis. So this can help you anticipate a dip or increase in revenue and aid in other practice business decisions. So, and we're happy to help you if you need an advisor in that situation. One of the biggest things that is going to probably be needed is that your staff is going to now need an extra back office staff, because what the recommendation is that the ancillary staff, whether it be RNs, medical assistants, LVN, LPN, not necessarily mid-levels, so not the expensive staff, but the kind of the lesser clinical staff, they're calling that a clinical team, scribes, etc., that they're saying that they're going to be doing a lot of the inputting into your EMR, EHR, and then the physician can move on with the next patient while that actual E&M is finished up by that ancillary staff. And we already got this year a relaxed kind of guideline where the ancillary staff can do a lot of the history, and the physician doesn't have to reiterate some of that history in the HPI. They just have to agree or review it and have documentation that supports that. So there's going to be some financial impact. New employees cost money, but apparently AMA feels that with that impact on the front end, you'll see a financial impact on the positive on the back end because it frees up the physician. So we'll see what happens on that. And then understand additional employer or payer or medical liability coverage requirements. So some employers or payers, I hate to say work comp because they are HIPAA exempt, but may not be E&M exempt from AMA, they may still require documentation of additional information above and beyond the new E&M visits and coding guidelines. Remember, AMA and Medicare are working closely together, but that doesn't mean that you don't have a health net or one of the payers, Blue Cross Blue Shields, any of them that say, you know what, we still want to go by the current guidelines because we don't agree. And they can do that. That's what they're there for. So they can have contract stipulations, and you need to be aware of it. Physicians need to carefully evaluate the flexibilities allowed under the new guidelines and ensure that their documentation will satisfy any other obligations and requirements by other payers that they're expected to fulfill. So the American Medical Association is engaging a number of entities to ensure that the burden reduction potential is fully realized. I'm not seeing it as being that much of a difference, more of almost a free pass not to be able to do certain things. And that's a problem for me. So you really have to start the process now as far as getting somebody in line who can get trained. And again, we're going to have some training modules for you. So keep a lookout on my website to start the process and make sure you understand what do they have to capture in the history? What do they have to capture in the exam? Since it says that's not going to be part of the scoring for an E&M service. And so my plan is to give you some of the minimalistic options and then give you some examples based on specialty. That's the only way to really do it. And then understanding the medical decision-making process. Because what's going to happen is that if you're basing it on time, then you're going to have one set of guidelines. And if you're basing it on medical decision-making, you're going to have another set of guidelines. And it's going to be different than that 50% or more counseling on the time thing. So you have to keep up on that and make sure that you're also understanding what's happening within that realm. And there's just so much to change and update and understand that it's important to make sure that you know who to go to for some of that information. And since this is something I teach on a regular basis, feel free to contact me if you need to hire us for your practice to do that. Okay, so we want to get to our coding question. And today it's about deep incision and drain services. So it says a patient, and this is from one of my New York subscribers, said a patient reported to the provider for an incision and drain of a foot abscess, and I thought the code choice would be relatively easy, but there are several options for foot IND. Can you tell me a little more about the coding option for these services? Sure. Okay, so if an IND is for a simple or single abscess, you look at the code 10060. That's an incision and drain of an abscess, and it's pretty straightforward. And then when the abscess is complicated or when multiple abscesses are involved, you might have to report the 10061, and that's complicated or multiple. So the difference is, just so you know the difference between simple and complicated. So a simple incision and drain usually involves a single incision of an abscess situated just below the skin surface. A complicated incision and drain can involve drainage, can involve multiple incisions, drain placements, extensive packing, and a more complicated wound closure as well. So when the INDs go below the service, your coding will also change accordingly. So you get more specific as to anatomy as well as to the provider's actions, then you're still going to get some possibly different codes as well. So let's say you did an incision and drain of a bursa of the foot. So your doctor got very specific. So in this procedure, the provider drains fluid from the affected bursa of the foot. And that's just so you know, that's a fluid sac that lies between the muscle, tendon, and bone. That would be 28001. If it was an incision and drain below the fascia with or without tendon sheath involvement, single bursa space, and so then this one also, the provider drains infected material that also involves covering the tendon, then that's 28002. And if it's multiple areas, then it would be 28003. So it's really based on the specificity of what your physician gives you in the note, basically a separate exact place on the foot, or if they just say foot, then you're back to the IND codes. So hopefully that was helpful. Today, our coding question is brought to you by HealthTerm, 100% web-based enterprise terminology system that enables data exchange and semantic interoperability in healthcare, a product of CareCom, carecom.com. So my personal tidbit today actually will help some of you that are living in California right now. Maybe you don't know this, but if you have a driver's license, that's not considered a real ID. The Federal Real ID Act places new rules on which forms of identification can be used to board flights within the U.S., enter secure federal facilities such as military bases, federal courthouses, and other federal facilities. So if you just have a driver's license in California, you have to get a real ID, which apparently has different rules on identification, not just your Social Security card, and you to be able to board domestic flights. So otherwise you have to get a passport. And luckily I do have a passport and I just renewed it. But if not, your California ID says federal limits apply and you can't get on a flight after October 1st, 2020. So I just thought I'd put that out there to anybody, mainly because I travel for my job. And for those of you that live in other states, I don't know how that's going to work for you, but just a photo identification or something that says California driver's license. There's one that's just used for driving, and apparently there's one that's used for everything else that is federally compliant, and it has to have our California bear with a star on it to be able to say that it is a real ID. So welcome to California, folks. So anyway, hopefully if you're hearing this and you live here, you can remember to do that. I know they're not making a lot of announcements about that, and I can just see it's going to be really fun in October going to the airport. So anyway, keep that in mind, and hopefully everybody can get that settled. Okay, everybody, make it a great day and a great week, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.